This was an interesting case of a 15-year-old who presented to the emergency department with right-sided weakness. So she was 15 and she had right-sided weakness and confusion while she was doing homework. There's no past medical history, no seizure disorder. She's not sick recently. In the emergency department, she denies headache, vision changes, dizziness, fever, neck stiffness, and had returned to baseline by the time she arrived. No surgical history, no drugs or alcohol. On exam, her heart rate is 92, her blood pressure is 111 over 71, her respiratory rate is 20, her O2 sat is 100%, and her temperature is normal. Her HEA&T, neck, cardiovascular, respiratory, and abdominal exams are normal. Her neurological exam is also surprisingly normal. She's alert 90 times 3. Her cranial nerves are intact. Her strength is normal in all four extremities. There's no drift, no dysmetria. Her gait is normal and her sensation is normal. And from a psych standpoint, her behavior, thought pattern, mood are all normal as well. In the ED, she had a complete blood count, a complete metabolic panel, a point of care glucose, and an HCG, all of which are normal. She had a CT scan, which we have here on the right side of the screen, which was also read as normal. However, while she's in the emergency department, she develops right-sided weakness, measuring 3 out of 5 in both her right arm and right leg. So let's talk about the differential diagnosis. Stroke, ischemic stroke, seizure, syncope we can loosely exclude based on her clinical presentation, although if really concerned, you can get an EKG. We excluded subdural hemorrhage on her CT scan. We excluded epidural hemorrhage on her CT scan. Her blood sugar is normal. Her sodium is normal. She doesn't have a fever or a white count, so meningitis or encephalitis seem unlikely. She's not hyperosmotic on her labs. She doesn't have any vestibular symptoms to suggest labyrinthitis. She doesn't use drugs, although most people would get a tox screen in this 15-year-old. She could be having a complex migraine, Meniere's disease, also without any vestibular symptoms, demyelinating disease, conversion disorder, cerebral sinus thrombosis, and malignancy are all still on the differential. So this patient ended up having an ischemic stroke. Okay, incidence is about 25 per 100,000 neonates, and then in children who are a little bit older, 1 to 13 per 100,000. Okay, half of these cases are ischemic, and that is characterized by a nerve deficit lasting more than 24 hours without any other clear cause, such as infection or tumor or something like that. Transient ischemic attack is by definition a transient stroke, which resolves within 24 hours, however, is predictive of developing an infarction in the future. On the right side of the screen, we show kind of what happens with a stroke. You have a vascular occlusion, decreased cerebral blood flow, decreased oxygen and glucose, which disrupts cellular metabolism, energy production, alteration of the cell membranes, leading to necrosis, apoptosis, and inflammation. Risk factors in kids includes congenital heart disease, vasculopathies, hemoglobinopathies such as sickle cell disease, infection, prothrombotic conditions, dehydration, sepsis, and trauma. About a third of ischemic stroke is attributed to prothrombotic disorders. So that would be like factor V Leiden as an example. And about half of pediatric strokes are idiopathic, meaning that the neurology team cannot identify a cause. Presentation varies widely, as you can imagine. A 6-month-old, it's going to be difficult to diagnose a stroke on clinically. As the child gets older and they can participate in an exam, that gets a little bit easier. But like most things in pediatrics, we rely on a lot of more subtle clues. Okay, so in an infant, seizure, hypotonia, apnea, decreased level of consciousness. In an older child, hemiplegia, aphasia, seizure, focal deficits. Because of this difficulty and perhaps the perception that stroke is rare, it is frequently mistaken for other conditions, and when combined with often nonspecific nature of presentations, this leads to a delay in diagnosis. On the right side of the screen, there are some clues which may help you figure out without any imaging that a hemorrhagic or ischemic stroke has occurred. An example would be hyperextensive or hyperextensible joints, which may suggest a collagen defect, increasing your risk of dissection. There's lots of stuff here. Evaluation is initially going to be a dry CT scan or without contrast. It's quick and it's cheap and can exclude hemorrhage very rapidly. It can also show clues of ischemic stroke and tumor and other things. MRI and CT or MR angiography are indicated in most cases. We provide a lot more information than just a dry CT scan. There's some labs involved, typically CBC, CMP, glucose, and coag studies, and then a coagulation workup is often indicated in kids, especially if there's any clues in the family history. Treatment is initially to recognize the clinical picture, which in and of itself can be challenging. ABCs, thrombolytics are controversial in pediatrics, but should be considered in consultation with neurology. Antiplatelet and anticoagulation agents are guided by the adult studies and expert opinion, not a large cohort of pediatric studies to draw from, but often involves low molecular weight heparin followed by aspirin. And in patients with sickle cell disease or hemoglobinopathies, an exchange transfusion is indicated. So in the case of our patient, she was diagnosed with a left MCA infarct, and I will show you on the right side of the screen here. This is her CT scan without contrast. And what you see here is this so-called dense MCA sign, which is an early but uncommon finding to suggest an MCA infarct. Of course, this is not vascular imaging, so this is a subtle clue, not always present. And then on the left, the right side of the screen, this is angiography, CT angiography, and you can see the MCA on the right side of the patient here. And then you see the same middle cerebral artery coming up on the left, and then it abruptly starts or stops where this arrow is, which suggests there's a filling defect. That loosely correlates with the dense MCA sign and her clinical picture, and thus the diagnosis would be an MCA infarction. The decision was made with a specialty consultation not to give thrombolytics, and the patient was placed on heparin. MRI, which is more sensitive but takes time to get, an infarct of the lentiform nucleus, caudate, and external capsule. There was a negative hypercoagulability workup, and then echocardiogram is also standard practice, nothing on the echo. Patient went home asymptomatic on day 6 on enoxaparin. The 3 key points about pediatric strokes. In children, it must be included in the differential for any child presenting to the ED with acute focal weakness or other stroke-like symptoms. The first year of life typically presents with seizures, hypotonia, or apnea, and in older children presents with more classic findings such as hemiplegia, aphasia, or seizures. Treatment is controversial and may include thrombolytics, anticoagulation, antiplatelet agents, and decisions should of course be made in consultation with pediatric neurology.